supply chain policy of 2016, which of course also prescribes rules and responsibilities relating to pharmacovigilance for the LMCUs and so on. Now, more importantly, why? Why should we care? We should care because as a country and as a people, we lean heavily on external clinical evaluations, including clinical and bioequivalence data to register drugs in Nigeria. And then also, we also rely on external data to deregister them. So what do we do as a people? Okay, the issues, the drug issues that have happened in the world, the rosiglitazone issue, the celecoxib issue, the stavudine issue, the efavirenz issue, the adenosine, how much data came out of Nigeria? But we consume this, we consume the commodities, we consume the data, we consume the technology, and we also consume the funding. Hello? So we should care. It is very important. We should start generating homegrown data. Next. Now going into the how. How did we perform the investigation? We did a cross-sectional review of this 6,965 ICSR randomly selected, sampled from the over 16,000 in the database, and we carry out all these research methods. Next slide. Now, key indicators. The other time we listened to the beautiful presentation about key performance indicators. Now, there are some key elements or parameters that should be in a good report. One is the time to onset, then the indication for use of medication, the outcome, the gender or sex if you like, age, dose, dosage, reaction, suspect. We here in Nigeria we collect concomitant drugs and suspect drugs, the country of origin. Now, what we did is an adaptation. The Vigigrade has its own parameters, but as a country, we needed something that will answer local questions. And so we did adaptations. If you look at the table, you will see how we adapted and tweaked some things from that of the Vigigrade. Next slide, please. Next slide. Now, what were we able to find out? Now, some of the key findings are this. You can see how the quality trend moved over the years. We have the magnitude of the quality of ICSR and then the percentage of the quality. Now, the blue bars there represent apparently in a year probably you collect 1,000 reports, and then out of the 1,000 reports you have 10 or you have 900 that are of good quality, and then in another year you collect 100 reports, and out of the 100 reports you have 99 that are of good quality. Now, apparently in 1 year it might seem as if you collected so many quality reports, but that's because you collected so many reports in that year, while in another year you collected a little number of reports. Now, the quality of the reports might seem to be little, but when you actually do the analysis, you will realize that you probably did better in the year you collected less number of reports than the year you collected so many reports. Next slide. Now, other analysis we did based on the parameters, we found out that where reporters usually have issues in reporting the dosage of the reports of the drugs used, and in reporting the outcome of the report, as well as the time to onset. By the way, time to onset is the time from where the patient takes the medication and the time where when the reaction starts. That's the time to onset. We realize that these are the three main areas where we are having issues. Now this again, the other chart also represents the average of poor quality reports as against the well-documented reports. Next slide. Now this is a very interesting finding we came up with. Somehow pharmacists, this represents the well-documented ICSR by category of reporters. By the way, in Nigeria, everybody reports pharmacovigilance data. The teachers, everybody, anybody that takes medicine reports reactions that they have. Now, we've always traditionally thought that pharmacists do better or do the best in reporting ICSR. But when we carried out this evaluation, we were surprised to find out that actually the doctors do better in reporting quality reports in Nigeria than the pharmacists. However, the pharmacists reported large volume of reports, but the quality was not that very good. While the doctors reported not so large, but the quality was very good. Incidentally as well, the nurses do better in reporting than the pharmacists. So these were some of the surprising findings that we came up with. Now let's talk about this. There is what we call the completeness score. The completeness score based on the algorithms for doing the quality of the reports. Now, when what is accepted as well documented is 0.8, anything less than 0.8 is not well documented. So in the Nigerian database as of 2015, we realized that no less than 43.5% of the reports in the database were of good quality. So this work will guide you or guide us. If we want to use the database for further evaluations, we'll know how to rely on that. It will also guide in planning for trainings, further trainings on adverse drug ADR reporting in Nigeria. The quality trend declined from 2009. In 2009, it was 59.6%. That's the quality of the report. But by 2015, the quality dropped to 39.7%. Now, pharmacists we have discussed this, time to onset, outcome, and dosage parameters contribute the most to poor quality reporting. Now, we did also questionnaires to 79 staff of the National Center, and the staff believe that the ADR form is actually not the problem, because we also try to look at is the form the problem, but we realize that the form is not the problem. Next slide. Now, in conclusion, we've seen that no less than 43.5% of the reports were good, and then we've also seen that this evidence to show that some critical elements of the ICSR were mostly missed. We've also seen the current ADR reporting form was not the problem. Next slide, please. Now, this is further readings, and next slide. And thank you very much.
Thank you very much, sir. That was a wonderful scientific presentation. Can we please put our hands together again for him? I noticed there were a few sensitive areas in that presentation. Please note your questions. There will be a panel Q&A session after the next presentation. And I remember before that presentation, I committed a regrettable affront, which if I don't correct, my professional career might be at risk. So I need to make that introduction once again. The person I'm about to introduce, for correction, this is his title: FPSN, FNA Farm, FNIM, and he's the president of the Pharmaceutical Society of Nigeria, pharmacist Yakasai Ahmed. Thank you, sir, for coming. So quickly, we'll take our next session. It will be handled on the topic anti-malaria resistance and the shifting sands of chemotherapy for the prevention and control of malaria in pregnancy. To do this is a lecturer from the University of Benin and also from the University of Jos in Nigeria, Dr. Wetkos Dayom. Can we please put our hands together for him?
Thank you. This is not to say I'm employed by the two universities, but it's a coincidence. At least I did the work in Benin and through the University of Benin, and that is what brought about joining those two universities together as I coming from the two. Good afternoon. I must also say I'm grateful to the convener of this meeting, not just for this presentation that I'm about to make, but for the exposure I've gotten from all the presentations on supply chain management. And I wish I would have more opportunities, even if it requires a training that will be awarded with a certificate. I wouldn't mind attending in future. Thank you very much. The anti-malaria resistance and the shifting sands of chemotherapy for prevention and control of malaria in pregnancy is what I have to present at this time. Next slide, please. Malaria remains a public health problem, not only in Nigeria, but wherever malaria is found, because it has defied all measures of eradication. And that has made it difficult to really put off the disease terrain. Malaria remains an important cause of morbidity and mortality in sub-Saharan Africa, South America, and Asia. These were reported incidences of malaria in 2015 according to World Health Organization 2016. And pregnant women and children under 5 are the most vulnerable. And these are due to certain conditions. Those children because of poor immunity, and then of course pregnant women with the changing immunity due to hormonal changes in pregnancy. Next slide. Malaria in pregnancy cause adverse pregnancy outcomes, which are very, very devastating, and which include low birth weight of infants, prematurity, intrauterine growth retardation. And these consequences have great implications on the health of both the child and the mother. The National Malaria Elimination Program of the Federal Ministry of Health, in conjunction with the guideline provided by the World Health Organization, recommend a 3-pronged approach to the elimination of malaria. And these include the use of insecticide-treated nets, the sulfadoxine pyrimethamine-based intermittent preventive treatment in pregnancy, prompt clinical case detection and treatment. Next slide. The drug for this program, IPT, that is the sulfadoxine pyrimethamine, is administered in 2 doses for HIV pregnant women, and then 3 doses for HIV positive women who attend antenatal clinic. And the use of antenatal clinic attendance or coverage is used where, when they come for antenatal clinic, these drugs are administered. And each dose, between 2 successive doses, should be minimum period of 30 days. However, this particular drug, the SP, is threatened by plasmodium resistance to the sulfadoxine pyrimethamine and the poor uptake of the program by both the users and providers. of these interventions. Next slide. Because of the resistance to, or threat of resistance to sulfadoxine-pyrimethamine, several alternative drugs have been tried as drugs or as a replacement for the sulfadoxine-pyrimethamine. But these drugs are either poorly tolerated or they are not as effective as the sulfadoxine-pyrimethamine. And this has not made it possible to change those drugs. Even those few that might still find some relevance, you find out that the mode of administration will not allow for the adherence that is easy with the sulfadoxine-pyrimethamine. Now, this, in addition to the declining burden of malaria in our setting, calls for an alternative intervention. And it is estimated that malaria infection declined by 26%. That's the incidence, while the mortality declined by 54% globally between the year 2000 and the year 2013. Next slide. Therefore, AHD, that's intermittent screening and treatment for malaria in pregnancy, using, for instance, artemether-lumefantrine as an intervention, is proposed as an alternative to the intermittent preventive treatment using the sulfadoxine-pyrimethamine. However, this will require randomized control trials to really showcase the efficacy and the safety, as well as acceptability and tolerability by the users. Now, the main objective that we set out to do in this study was to compare the efficacy, the tolerability, and the acceptability of an AL-based IST with an SP-based IPT in the prevention and control of malaria in pregnancy. Next slide. The specific objectives are outlined. To compare the impact of both interventions on late pregnancy, hemoglobin concentration, and the birth weight of babies. We use these two outcomes as the yardstick to measure the performance of each intervention. The tolerability of both interventions among pregnant women, and then to also compare the acceptability of both interventions by pregnant women who are exposed to these two interventions, as well as by healthcare providers at the facility levels. The study was carried out in 5 antenatal clinics in Edo State between February 2014 to September 2015. And then it is reported that Edo State, the antenatal clinic uptake, according to the National Demographic and Health Survey of 2013, has an antenatal uptake of 73%. But the uptake of the SP, that is the IPT, using the SP, is just for one dose is 3.2%. While for the 2 doses that is recommended, the uptake is just 1.6%. And this goes to show the poor uptake of the SP-based IPT in that setting. Next slide, please. Let me see the next one. Next one. Well, we use these definitions to draw conclusions at the end of the study. Late pregnancy, hemoglobin concentration is defined as severe. We defined severe anemia to be when the hemoglobin concentration is less than 8 grams per deciliter, and then it is moderate when it is between 8 to 10 grams per deciliter, while it is normal between concentrations that are from 10 grams per deciliter and above. Now, infant birth weight was defined as low when it is less than 2.5 kilogram, while it is normal when it is 2.5 kilogram and above. Next. We use the method of Tabo et al. 2010 in calculating our sample size. And here we assume that the difference between IPT and IST SP in terms of late pregnancy anemia and low birth weight to be not more than 5% and 4% respectively. We use this as the effect size to calculate, and with 90% statistical power and allowing for 20% attrition in follow-up, we came up with a sample size of 1,110 per study arm, and since we had 2 arms, the total sample size was 2,220. Next. Eligible pregnant women were screened and randomized into the study arms and treated according to the protocol. The SPIPT, those in that group, which is the current intervention, received the 2 doses of SP across from 16 weeks of gestation to the 32 weeks or above 32 weeks of gestation, depending on the time of enrollment, the gestational age at the time of enrollment. And this were followed up. While those in the artemether-lumefantrine-based AHD were screened for malaria, and these screenings, we used the rapid diagnostic test kits to screen for malaria at this level. Those who were found to have positive or to have malaria were treated with artemether-lumefantrine according to the national protocol. Hemoglobin concentration was measured using the HB meter by Akon Laboratories, while malaria test was done using the rapid diagnostic test, as I stated earlier. Next slide. Next slide. Next. Yeah, this is the flow chart for enrollment and follow-up visits that we used at the end to answer the consult statement. Next slide. Apart from the clinical assessments, we also embarked on qualitative evaluations to ascertain the acceptability, the tolerability of these interventions across the 2 settings by both providers and consumers of the interventions. The acceptability and tolerability and the feasibility also of the IST implementation were evaluated at exit of the study through a focus group discussions. And 4 focus group discussions were held with at least 15 women post-delivery in each group. And discussions were thematically followed. We followed thematic questionnaires that will help elicit the necessary response as to whether they tolerated or not, whether they accepted or not, whether the qualitative, the next slide please. Now this was the chart, the consult chart for the focus group discussions. Now this, the last boxes, group 1, group 2, group 3, group 4, just represent the areas from where these women were coming from in the 2 interventions. The left arm are those in the SPIPT, while the right arm are those in the IPT, the ALIST. Now at the end of the studies, based on their outcomes, pregnancy outcomes, and also the late pregnancy hemoglobin concentration that we measured, we are able to group them such that they come from various backgrounds within the study with different experiences of pregnancy outcome, in order for us to see that their responses would be balanced. So we had 4, the last 4 boxes represents the different groups for the focus group discussion. Next slide, please. Next. Now what we have here, in-depth interviews with providers. We conducted that at least 2 personnel who are directly involved in rendering care to these pregnant women at the different facilities were interviewed. And interviews were conducted using a set of questions that were already prepared to elicit the needed responses. And facility survey for staff and infrastructure was also done. And this was to see if For instance, if the use of artemether-lumefantrine-based intermittent screening and treatment becomes a policy, whether those facilities will have the requisite requirement to do that. Next. Descriptive and inferential statistical analysis were performed. Risk difference, risk ratios with their 95% confidence intervals were calculated. Both intention to treat and per protocol methods were employed in analyzing or assessing the primary outcomes of the study. Qualitative data were analyzed based on the themes that emerge from the discussions or from the interview, as the case may be. Next. Okay. Next. This is the consult statement for the study, where we have 2,267 pregnant women were enrolled, 1,129 in the IPT arm, and then 1,138 in the AHD arm. And eventually, at the end, the per protocol analysis number is there. Those analyzed intention to treat are there at the end. Next slide. The results indicates here, we can see in the participants' demographics, we had the responses as presented, age, baseline hemoglobin concentrations, and so on, that were presented. Next. The study shows that at baseline, compared with the late pregnancy, we have an improvement in the hemoglobin concentration across the two interventions. And this shows that the intervention, both SP-IPT and ALIST, had impact that were measurable as interventions, which helps in improving the hemoglobin concentration and preventing anemia in pregnancy. Next. Comparing the two interventions, if we look at the mean hemoglobin concentration in late pregnancy and then the infant birth weight, we see even though in the ALIST, which is the intervention on that test, the values are higher than those of the SP-IPT, but the differences are not statistically significant. Next. While factors associated with anemia in late pregnancy were done, we compared the two interventions and see that the risk ratio is just 1.003. And because we had a baseline difference in hemoglobin concentration, we now adjusted for that. That is the one that is start. But still, both the the unadjusted and the adjusted risk ratios are not statistically significant. But when we come to the baseline anemia, those who had baseline anemia and those who didn't have, both those who have and those, both the adjusted and the unadjusted risk ratios were statistically significant. Next. I understand. Yeah. Now, we also tested in terms of the birth weight. There is no significant difference between the two interventions in terms of the risk ratio. Next. Now, the non-inferiority statement, the two-sided 95% confidence interval shows that the risk difference, which is the primary endpoint for this study, was 0.003 with an insignificant p-value. And also that's for the late pregnancy anemia, and also for the low birth weight, the risk difference was also very, very small for ALIST compared with the SP-IPT, which is not significant. And since the upper boundaries of the 95% confidence limits are lower than the values set for inferiority, that's 5% and 4% differences, which we assumed in calculating the sample size, it shows then that the ALIST is not inferior to SP-IPT in any way. Next slide. This is just a diagrammatic representation of the two. 0 is taken as the control, that's the SPIPT, while to the right is positive 1 and the left is positive negative 1. But if we see the risk difference is almost 0 for ALIST compared with the SPIPT, and it's at this level that we must accept that there is none is inferior to the other. Then this comparison of adverse birth outcomes between the interventions, even though there were more adverse outcomes with respect to miscarriages, preterm deliveries, and fetal abnormalities in the ALIST, in terms of their risk ratios, the p-values are not significant. Now the next, the qualitative evaluation, I will just say what we achieved or what we got. The qualitative evaluation, the interview we had with the providers, most providers in these study facilities indicated their willingness and preference for IST, that's screen and treat policy, rather than the SPIPT, for various reasons, some of which include the fact that the women, the lack of uptake of the SPIPT is that for every drug there must be an indication. An indication is a motivation for taking drugs. So most of them, unless they are forced to take it at that point, which is of course the right way to administer the IPT, but they would prefer to say they've not taken anything and therefore they will want to be given to take at home. But when you trace, they don't even take it at home because they don't like taking the drugs when there is no compelling indication. These were the reports of the providers. And secondly, they in themselves believe that they want to see that these women actually have the malaria and are tested, or are tested and have it, because that will be a motivation for them to take it, even if they are not showing any symptoms. On the part of the provider, the consumers, that's the pregnant women now, they had different motivations for taking drugs. They said in the report that they don't like taking drugs, especially most of them considered the dose of the SPIPT, that's the SP, of 1,500 milligram sulfadoxine and 75 milligram pyrimethamine. They considered the dose as too high for their pregnancies. And so that is what makes them not wanting to take the drug, especially when they don't have any symptoms of malaria. These were the reports they actually presented. But in terms of preference, they preferred to be tested, that is to be screened. And if they are found to have malaria, they will take that treatment seriously. And we discovered that the IST will be a more acceptable and presentable strategy for prevention of malaria in pregnancy. Well, he has jumped to conclusion. But the facility also, the facilities were not found to be adequate enough to support an IST program. And so, in terms of personnel and infrastructure, so if an IST is to be instituted in any facility, these need to be put in place. But the outcome is what matters. It may be costly, but the outcome will be more desirable. So in conclusion, I would say an AL-based IST is as effective as SP-based IPT for the prevention of malaria in pregnancy, and that AL-based IST is not inferior in any way to SPIPT, and that pregnant women in these settings showed higher acceptability and tolerability despite the pains of bloodletting for the test. They felt it's still better and accept and tolerate that than the IPT as a strategy for control of malaria in pregnancy. The next. Providers in these settings recognize the benefits of IST and preferred it over IPT for control of malaria in pregnancy, and that SP-based IPT is better than AL-based IST